the world of healthcare, we have a lot of acronyms that we use in our everyday language. The topic today, CHEMS, or CHEMS, is no different. It stands for Community Health Emergency Medical Services. The panelists here with us are going to be sharing their experiences of transformation from a traditional EMS model of care to the CHEMS model. They'll give us a brief look at how this will benefit the healthcare systems and other community agencies that they work with, and they'll also give us some insight as to the impact on patients, families, and caregivers under the CHEMS initiative. So thank you so much for joining us here today. Let's just go around the room and introduce yourselves, kind of tell us what role you play and what your geographical area is that you work with for your EMS location.
Perfect. So I'm Travis Spencer. I work for Payette County Paramedics. I'm a paramedic and a community paramedic, and we serve the area of Payette County. So.
Juan Bonilla, Donley Rural Fire Protection District, and Donley is in Valley County, and I'm the fire chief there.
Nice, thank you.
My name is Mark Babson. I'm a community paramedic with Ada County Paramedics, and we serve Ada County.
Great. So we have quite the mix of rural and urban areas represented here, so that's great. Thank you so much. And I'm Dawn. I'll be your moderator today. I work with the SHIP State Evaluator team, so I'm somewhat versed on all things related to SHIP and community health. Okay, well, thank you so much. Can you share a story with us about how you became motivated and involved in the CHEMS program? You want to start, Mark?
You bet. So when this concept first started to come out nationally, our director at the time was very interested and brought that concept back to our agency and introduced it. And when he described what a community paramedic or a CHEMS provider was, I became pretty intrigued pretty quickly. I had always wanted to kind of figure out what I could do for a patient in addition to the 911 medicine that we deliver. I always felt that there was something I wish I could do one step further than what we had. And then community paramedicine was a way, I thought, for me to do that. And it would allow me to operate, I thought, at the height of my licensure level. And so when the concept was first introduced, that's what first intrigued me.
Perfect. You want to add?
So I would add to, after hearing about it when I was in the East Coast at a NASEMSO meeting, it was like, this could be something I bring back to my agency and help those gap patients that are not being able to be seen or unable to utilize the system that was already provided in our county, and enhance it, as well as I also looked at it as what was so intriguing is I also looked at the fact that it was going to enhance the EMTs and paramedics that we had and make them better EMTs and paramedics and get more of that one-on-one rapport with our constituents that we're serving, and our boots in the ground EMS individuals would be able to grow, as well as help our population health grow and be more healthy.
Travis, do you have a different story?
I think it's kind of the same as them. We kind of identified some issues with chronic patients and trying to figure out how to help them beyond just picking them up and taking them to the hospital. You know, you get kind of frustrated picking up the same people over and over again, and you feel frustrated that you can't find a way to help them. And so I think the CHEMS program kind of introduced a way for us to help them a little bit more than just drop them off at the hospital. And we're able to better their lives. And I think the majority of it came from going through conferences and seeing Ada County kind of put their program together that opened it up for us. So.
Yeah. Tell me a little bit, just expand, from a rural perspective, you've got a population that's spread all over. Compared to a more urban setting, well, the population is huge, and they're spread quite a ways, but there's a vast difference between the two. So how was it more motivating for you in the rural communities?
I think with us, we kind of have less resources to depend on to help us deal with some of the issues. And so we have to be the people that find the resources or help the patients find their resources that aren't as easily available in Ada County or some of the bigger areas, and connecting those people with those resources.
I'd have to say, because I think it's actually nicer that we're in the rural community. It may be there are a little more challenges with the community paramedicine, as well as providing health care to our population health. It's just that what I think is because we know everyone in our communities, this has given us more insight and more one-on-one with those individuals, and helping them and being part of that health team with their whatever ails them or whatever they need, and just makes us more involved in the community. And I think that was the biggest intriguing part in the rural part. We knew it was going to be challenging because of the resources that we have at each station, as well as what the resources in our small hospitals have to give us. So we were looking at, well, this will be a more one-on-one time with that patient, and help them in the more non-emergent rather than in the emergent factor.
And is that different for you? Because urban, as a person who doesn't know a whole lot about what you guys do, it would seem that you have more resources, but you don't know each other. So is it different for you, or do you have the same experiences?
I think fairly similar, to be honest. For me, when speaking with Travis and Juan and other agencies across the state that are implementing a plan, there are some consistencies as far as kind of the concept. And I think whether it's urban or rural, and if a service is volunteer or paid, patients and the people in your community can have similar challenges. How do you access that healthcare system? How do you learn how to manage your chronic health conditions? And some of those things are, I think, really personal. And so you get to know the patient on that personal level. And again, whether you're in the urban setting or the rural setting, I think the concept of a community paramedicine or a paramedic fits great.
Do you all find that you have some individuals who utilize the system through the emergency services quite frequently, or how does that come to be?
I mean, one of the things that we use our community paramedic program for is identifying the high utilizers and trying to help them so we can reduce the amount of ER visits and the amount of ambulance demand. So yes, we do depend on that highly.
So you probably get to know them a lot better than some of the infrequent users.
I personally think you'd have to. You know, if someone is accessing or utilizing EMS services in the emergency department over and over and over, what I've found, at least through my work with community paramedicine, these guys, I think would probably find something similar, is that people, they don't want to do that. I think inherently they want to be able to manage their own health or navigate that healthcare system. And for a variety of reasons that we learn about through our community paramedic activities, we learn why that is. And that's where you can make that biggest difference.
So describe for me what's involved in your transition from the standard model of providing emergency services into that CHEMS model of care. Who wants?
So I guess what we look at is there's more education and more training that needs to happen so that we can have the communication that we need with the healthcare neighborhood agencies and the stakeholders that we're going to be participating with and becoming a tool in their toolbox, if you would. And what that does is allows for a change in how we're doing things in the fact that we're not in that emergent response mode. We're now in the non-emergent response mode. And so it allows, when we look at our run volume, when we looked at our run volume in Donley, we were like, okay, we had 100 runs. How many of those were emergent, really emergent? Well, we noticed that that number was less than 10%. And we were already doing a community type system, but it was them calling 911. So what this allowed for was a transition now. They're not calling 911, they're being referred and going on to the system of CHEMS, and we're getting them before they do those 911s or going to the ED regularly on a regular basis or the clinic for things that we can handle at their home with the patient care provider and the team of individuals helping them through their time of need.
Fantastic.
I think in a 911 setting or an emergency setting, you're dealing with an acute problem. You're just dealing with their breathing problem or their CHF exacerbation. And in the community paramedic world, it's more of the dealing with everything. It's chronic conditions. So, how do I maintain this from flaring up again? Or, why am I taking all these breathing treatments? To, maybe even as far as going as how do we prevent falls in the home? Or how do I get people to stop smoking that causes greater health differences? And so I think it's changing your mind frame from dealing with the acute stuff that you can fix right now to kind of dealing with more chronic issues that take time and take more resources and more effort.
Mark, do you have the same experiences in the larger populations as well?
I think so, yeah. I would ducktail a little bit off of what Travis said. For me personally, the two things that I kind of realized when I was making that transition from solely providing 911 services to the CHEMS services that we provide, I had to change my mindset a little bit about what EMS is. I had to realize how much benefit that we provide to patients or that we can be much more for the people in our community than simply a ride to the emergency department or handling an acute situation. I think that we can be much more than that. And then the second thing was to realize what I think is kind of the uniqueness of EMS and EMS professionals, and then taking that uniqueness and seeing how it can be integrated into the larger healthcare system delivery model. So, for example, EMS, I think EMS professionals are one of the only professionals in the healthcare continuum that has to communicate with every single person or organization involved. So on the 911 side, we'll have to deal with and communicate with patients in their home, in an emergent setting, bystanders, family members, maybe patients that speak another language. We have to deal with facility, nursing home staff, potentially depending on where the call is. Then we have to subsequently communicate with emergency room physicians or cardiologists or trauma surgeons, and we've had to hone that skill set to be able to communicate what we're finding and what we need to all of those various patients or people. And so just the fact of being able to utilize that skill set, which is unique to EMS, is something that I had to realize.
And so you talk a little bit about the next question that I wanted to discover more about is the roles and the workflow of people who are handling these types of calls and in this kind of a setting. What are some specific aspects? Do you find that you wear a lot of hats in a community health setting compared to just answering that 911 call? Is it different for you in an urban setting than it is in a rural setting where you maybe have talked about those lack of resources? Can you explain that a little bit for me? Travis?
So, I mean, you talked about it. We wear lots of hats. I mean, it's not just we're there for, your acute problem and dealing with their respiratory issue or their CHF. We're there dealing with the mental health side of things. We're dealing with getting them food from Meals on Wheels. I mean, you have all these different aspects that you aim to try to help this patient. And so a lot of times you are putting on a different hat every single time. Sometimes you're just there to hold their hand and talk to them and give them company. And then the next time you might be there trying to help them with an acute issue, trying to prevent them from going into the ED. And the next time you're there, you might be there just to, make sure they have food. So I think you're right. I think we wear lots of hats, and I think it's the same all the way around, whether it's urban or rural.
Anybody want to expand on that at all?
So yeah, definitely it's a lot of hat wearing, and what adds to it too is it's like we're also fire, so we're a fire-based EMS system. So we're wearing all the fire hats plus all the EMS hats on top of that, and then going into the community health, now we're adding more hats, and I think that's what we have to do in the rural and remote communities. Is we can't just specify here's the kind of EMS people we're going to be, or here are the kind of fire people we're going to be. You have to be able to control and be able to help all service type needs within the constituents that you're serving. So it's the hats just continue to pile up as you go, and you start to build your service so you can provide better care for your constituents.
Do you have anything that you'd like to add?
Well, I think that's a great question, the many hats or what we have to wear. And I think for me, it goes back to what we all discussed a little bit was that mindset shift. And I think we wear many hats because we're looking at patients differently now. We're looking at the patient in a more holistic way, looking at their whole situation and not just that acute call. And so when you do that, it kind of necessitates wearing a ton of different hats because when you look at that whole situation, so much is in play when it comes to a patient in the healthcare system or navigating that you have to be able to wear those hats.
Is this a one-size-fits-all approach?
Well, no. Well, so concept, yeah, I think the concept of just utilizing EMS personnel and infrastructure in the larger healthcare system delivery model is across the board works, but it's so locally tailored to those needs of your community and your patients and the providers and the relationships that you have established. And I don't know, I think concept for sure is across the board, but definitely what you do I'm looking at these guys to make sure I'm not misspeaking.
You're speaking correct.
Yeah.
Yeah.
I mean, take an example is Ada County probably has a higher homeless population than Payette County, and so they're probably going to focus a little bit more of their program on that versus us that probably won't waste our time with that because it just doesn't fill the needs of our community. And so you will see that our programs are identical in a lot of ways, but then they each have a little branch off of their own that kind of does a specialty program on top of that.
Depending on the needs of each community.
Absolutely.
And that was what the state has helped us develop in each of our agency types is because they're allowing, and with our education models, that allows for here's the basic concept of what you're going to be providing, but now take that home in your field internships, work with your healthcare neighborhood, and build the system you need for the type of individuals you're going to be serving and the type of service you want to provide. So there's that unevenness of, hey, you're going to all run the same way based on this and these protocols, but you're going to be able to tweak and move and go in different directions so that it fits your model and your service you want to provide.
That's fantastic. How does it contribute to a value-based model of healthcare delivery? So if a physician, a primary care physician, is treating a chronic medical condition in the office, and let's say they're a frequent utilizer,
Okay.
and they have a lot of emergency calls, how does CHEMS contribute to lowering the costs maybe of that individual's care over time? How do you see that working together?
Well, for me, I think depending on the initiative, it can vary, but I would say for me it goes back again to kind of that mindset shift, and then also going back to the uniqueness of EMS. When a clinical plan fails or the structure of a clinical plan starts to degrade, sometimes EMS practitioners are the first ones to be called on the 911 side. And so that uniqueness of having that knowledge and having those interactions with the patient on the 911 side, it gives us a perspective that I think is what is needed in that medical neighborhood concept or that patient-centered medical home concept. And so when you're talking about value, I think that has been maybe that missing piece. And so to have that perspective and that interaction that's unique to us, I think that's where the value comes from with utilizing CHEMS for the primary care provider or the specialty or the other healthcare providers, because it's unique to us.
Do you see lowered rates of utilization in some of the cases that you've worked with so far?
Oh yeah, for sure. So far some of our pilot programs have definitely proven that. And then I think it's also shown that we can help patients learn how to navigate that healthcare system and feel more comfortable managing it on their own, especially if at some point if they're not on our service anymore, or if they've graduated from certain programs. I think that's the other unique part of CHEMS.
Yeah, definitely. I think the value-based, when you keep bringing up the lower of rates is I think what's going to help facilitate that mechanism is we're showing ourselves as an EMS system that's, hey, we're here, we're boots on the ground. We probably know these patients better because we've seen their home settings, and we can help and be part of those healthcare neighborhood teams that are already assigned to that, and now we're getting to play a part in a role as being part of their healthcare team, and at the home setting on a non-emergent level. And I think what that is as you look at other systems that have been going on so well, and they're growing and growing throughout the country, you're starting to see the benefit to the cost of healthcare in those communities, and how much savings there is because the utilization has gone down and we're getting a better population health. And on top of that, and those individuals that they're looking at in their data sets are like, here's patients that are on the systems, here's patients that are not, and here's how it's benefiting the overall circumference of the system, including the economic factor of what it's costing to give health care in those particular communities.
So I think, can I answer your question? Physicians always see a certain amount of that patient. They see a 20-minute office visit maybe once every 4 months. they don't get to see why that patient keeps coming into the ER or why they're coming into the primary care so much. And so if you have, like, let's take a CHF patient, for example, that comes into the ER because they continue to have exacerbation of their CHF, the physician's like, okay, well, maybe they're not taking their medications or maybe they're not doing it correctly at home. But we find out more of the picture. Maybe they're unable to fill the medication due to finances. Maybe they're not very knowledgeable about low sodium diets. That's something we run into quite frequently. Or, just something as simple as, maybe they have a huge fall risk, and the physician doesn't get those eyes on the whole picture. They only get that 20 minutes or hour that they're in the ER or in the physician's office. And I think being able to utilize CHEMS to kind of get a greater idea of how that patient's situation at home is will overall improve that patient care's health, or that patient's health, and then which will overall reduce the utilization of that.
Mm-hmm. And can I clarify one thing?
Yes.
A CHF patient, congestive heart
Congestive
failure?
heart failure,
Okay,
yes.
thank you. Thank you very much.
EMS is acronym heavy. Yeah,
Yes,
you'll hear
yes,
that a lot.
the whole medical field is kind of acronym heavy.
Right.
So what is the major barrier that you would urge fellow CHEMS agencies to be aware of as they kind of embark on this journey? Juan,
I
why
guess
don't
I'll
you
start
take
with
this
that.
first?
So I wouldn't say a major barrier, but there is barriers along the way. And generally that is, like in everything we do, communication and getting out what CHEMS is, what it's going to provide, and the outcomes you want to achieve. Those are huge. So getting that communication out to all of your healthcare neighborhood agencies and stakeholders that you're going to be assisting with, and showing, hey, we're this boots on the grounds tool in your toolbox that you can utilize to capture that gap of individuals that can't use or aren't utilizing the system or unable to utilize the system. Those are barriers you have to overcome, and those are, I think, the biggest barriers is getting the right people in place, and then getting their supervisors and their governing boards and their boards of their agencies on board, and giving them the opportunity to participate and facilitate and help with the implementation and development process. Those were our biggest hurdles, rather than barriers, hurdles that we had to overcome, was just getting everybody at the same table, and then allowing and not being so rigid that here's our steering committee and then, oh, we forgot this agency or that agency, and then not allowing them in. It was like, please, with open arms, come in. We want your input. How is this going to affect you? What can we do to make it so that you see the importance of the program?
Because there's secondary benefits or secondary exacerbations of, fouling up the system, right? No matter which direction you would go. Great, Travis?
I think a big barrier is people hear paramedics. You want to do what? Because they're so used to us just picking up people and dropping them off at the hospital. And so it's reteaching people that, hey, we can do more to help our overall health care of our community.
Mm-hmm.
I was going to
like to
actually
add?
say exactly what Travis said. I think when we first started, one barrier that we identified fairly quickly and realized that we were going to have to handle in order to move forward, and I actually like what Juan said, not a barrier, hurdle, yeah, is that we had to kind of take a step back when we initially started to engage our system partners or organizations that we thought we would want to partner with, and we had to explain what EMS was in general, because so many people think that EMS is just car accidents and heart attacks on the 911 side, and it's so much more just on the 911 side. And so we realized that we had to kind of explain that to our system partners or organizations that we were going to engage with. And once they had a good understanding of what EMS is and what EMS practitioners do on the 911 side, it's almost as if light bulbs started to go on over their head, and they realized how they could potentially partner with us or where we could be utilized in their organization to maybe fill some gaps. So for us, that was kind of one of our biggest hurdles.
And that's really surprising, because I would think that the number one barrier would be funding or education. So I'm really surprised to hear that. The hurdle is communication. Can you speak to those other things? I mean, are those realistic barriers or challenges that you face? Or
I think financially, yes, that's a huge barrier. We cannot bill for this service right now, and so you have to find other sources of income. And, in our agency, we are utilizing the CHEMS program on overtime in order to fulfill the appointments or to follow up with patients. And so I think over the long term, if we don't find some way to sustain this financially, it's gonna be a burden on our agencies.
Mm-hmm. Mm-hmm.
It's going to be one of those things that we build, and then all of a sudden people are going to realize the importance, and their family members and their friends they're going to want them to participate because they're going to need the service in some fashion or form. So it's going to grow so rapidly that we're not going to be able to continue with how we're funding it now, which is like with our district it's strictly coming out of our budget right now. We're trying to facilitate some funding to help the program continue. And we know that that's going to end. But the other thing is we got to remember the gap of individuals that we're trying to cover. They're usually underinsured or not insured at all. So we're looking at help from how other agencies around the country have done it and getting payers to help facilitate those funding mechanisms. And because of the cost savings that we're going to have them occur, they're going to get so many cost savings per patient. Well, give us some of that cost savings so that we can continue the service and help it grow. And that's what I know the state's working on right now. That's what we're working on with those payers and having those discussions, because funding is huge. And then the education and training portion is it's not cheap to send students out, but the state here has helped really well. I mean, you make a few phone calls, they help you get some funding mechanisms. A lot of the state's helping right now with a lot of individuals going and get that so they can build these programs so we can show the importance and hopefully get some more individuals to want to participate so that we can get our personnel educated and moved up.
That's great that there's innovation here locally as well. Yeah.
Yeah, on a state level for sure. You bring up a great question, I think, about, of course, financial sustainability or education, and those are definitely, I think, structural hurdles for sure. And for us, though, when we first started, granted the concept was still so new, we began our program roughly 2012.
Wow.
So we had to start kind of from scratch. But we feel like even if those mechanisms were in place, if there was already a financial sustainability plan, which unfortunately there isn't, if there was already standardized education that everyone went through, I still think it would benefit an agency or an organization to really start, though, that conversation of what EMS is, because I think that would open the door to wanting to learn or to partner with us or learn more about us. Moving forward, financial sustainability is a tough challenge for us. And I think when these partners or payers or hospitals or whoever, if they understand what EMS is first, then for them, they can kind of work it into their thought process of how do they fit into a payment model, or what does that look like, or what is the value, the financial value that they're giving us. And so I just think they have to have a base understanding or knowledge. I don't know if you guys ran into that as well, but what you mentioned are structural hurdles for sure that moving forward, we, I think, as an industry are going to have to address for sure.
Sure. In what ways has the implementation of the CHEMS model affected your team and how you interact with other community agencies like maybe emergency departments or law enforcement, things that you might see or interact with differently?
So what that done right there is it's allowed for a better communication model of us going and grabbing a hospital person and saying, hey, we need to have these conversations. I need to know who you are. You need to know who we are. To go along with Mark said is sort of explain who we are as EMS and that we're out there. And it's funny because every time I go to DC to do EMS discussion with delegates or whoever, you spend the first part of the day explaining what EMS is, and here it is, how old are we now? And it's because they really don't grasp what we do every day. So I take that home in the local level, and you have to explain that, what you are, what you've been doing for 30 years in Valley County as EMS folks. So going and getting law enforcement involved and getting all those healthcare agencies in the neighborhood involved has been exciting because everybody's starting to realize all of the hats that we do wear and how we're really a vital part of their infrastructure too, and their foundation and how they're building all depends on what we're doing right off with that patient that we see right beginning from start. So it's allowed for a great communication hurdle to be demolished a little bit so that we can have those open communications, and we're actually getting seats at tables that we've never been able really, we had to like sort of sneak our way in there. They're like, hey, how come the EMS folks haven't given their input
Right.
on this today?
Right.
They're wanting us at that table now.
That's awesome.
Well, and I think with the rural areas, we have a lower amount of people that we have to work with, and so I think that partnership is very strong. So we work really close with our law enforcement, where they're actually our QRU out in Payette for a lot of our medical calls. And so now we've actually expanded that even more to where, you know, if they see something that they need to refer to us, it's an easy process. There's no, you know, what paperwork do I need to fill out? It's, hey, knock on our door and come say, you know, well, this is what we need to do. And I think it's the same thing in the emergency department as we start communicating more and more with the ER about, you know, this is a patient that we've seen quite frequently and they're on our CHEMS program and this is what we're trying to do. I think the ER docs have been more receptive to that too, and our primary care doctors, and I think it's opened up the communication and better patient health care and get those talks done that never used to happen.
I mean, I would say the same thing. I think partnering with some of our allied agencies or system partners through CHEMS programs have strengthened the relationships that we had on the 911 side. And then I actually, to be honest, not only do I see a benefit to them, but I get a benefit. I've learned more about law enforcement and emergency departments and their challenges and barriers and successes. So I definitely think it's a two-way street, and that those CHEMS programs have kind of been the conduit for that.
How has the implementation affected your work with patients, families, caregivers, and people who are, you know, needing some life-supporting services, as well as you know, the non-emergency contact?
Well, for me, being a CHEMS provider has really changed. We actually had a conversation about this earlier today. It really has changed how I look at patients and their situation as a whole. And I really do believe that people really try the best they can with wherever they are. And with the resources they have and the knowledge that they have. And so now when I'm on a 911 ambulance, I often am spending much longer on the scene than what I used to, sometimes to the dismay of my partners. I am asking additional assessment questions that I never used to. Some things even like, oh, are you a smoker? And if they say yes, I ask if they want information at the emergency department about stopping. I've had more interactions with the emergency department social workers because I have more of a CHEMS concept when I look at patients now, even on the 911 side. And that, I think, as well, is now kind of being passed on to my partners that work with me that maybe aren't community paramedics or involved in CHEMS, but we start to have discussions or they see those interactions, and I think they as well start to look at patients a little bit differently and want to inquire more about why they're in the situation they're in, and maybe is there more we can do for them. And for me, it really has changed how I deliver medicine, and it's on much more of a patient whole or a holistic way of looking at a patient than before.
And what kind of feedback are you getting from the patients?
Oh.
My patients love me.
Yeah, because of his modesty.
Yeah.
Yeah. No, I mean, we've had really good feedback from our patients so far. You know, we have a 90% success rate with people enrolling into our program right now. We've only had one patient that didn't enroll, and when they're done, we're no longer healthcare provider and patient. We're friends, and so I think that's the importance of this program is helping these people like a family member would, and helping them find the resources that they may not be able to find. And I think that means a lot to them. And so I think that opens up their hearts, it opens up our hearts, and it helps us be better people.
I would say that's why we have a CHEMS system now in Valley County, is because we had one particular patient as we were developing the CHEMS, and I ended up taking that patient and treating him like I would a CHEMS patient, not just because it wasn't a 911 emergent call. And all of a sudden the healthcare neighborhood started to realize the rapport I was building with that patient as that person was manic because he had a behavioral health issue, and helping him through his medication types. And it got to the point where we built those friendships, and they could see that EMS is not only about giving medicines and helping them in their acute. We have this sense of homegrown community provision because we're helping hands people, especially because you know how our makeup of our departments are. We help each other, we have this great family rapport, and we take that to our patients. The healthcare neighborhood started to see that and realize this is the importance, this is the kind of patient care we're going to get. And then the EMTs were noticing, and paramedics in my department were noticing, look how the chief has evolved with this one patient. He's now a better patient care provider. So it helps. And when I listen to Mark talk, you know, how you're now giving up this thing, it's the cultural shift and evolution of this is what a new EMT is going to look like, a new paramedic. It's going to be common practice. And us older guys are going to be moving into that common practice, and we can teach as the new people are coming up. That'll be already ingrained in them. They'll be already those holistic type patient care providers and clinicians as they go out.
So can you just give me a brief example of the difference now between an emergency call and a non-emergency call? How do those two things look different?
And I apologize, do you mean a 911 call and then a CHEMS visit, or do you mean?
Yeah. Because most of our viewers will probably be, you know, people who are not familiar with the CHEMS model. And so we'd want to kind of expand on what does that look like now that it's different.
Well, the nice part is we're not waking up at 3 in the morning anymore to alarms and bright lights. I think you take the 911 call and it's an emergent thing. So if somebody calls 911, we have to hurry to get into the ambulance. We drive to their house and we have to take care of them for their acute problem. In the CHEMS thing, it's more of we get a referral, we call that patient or we make contact with them, we make an appointment, we show up at their home during that time, and then we provide that service. And then there's even a backside of that where there's following through with a bunch of other things that maybe in the 911 side we didn't follow through as much with. Once they're in the emergency department, you've met that need in the 911 side, versus the CHEMS side is you need to make sure what you just did comes back and actually affects the patient and changes things. And so there's always a follow-up with that. And so I think it's kind of a different model completely. I mean, it's hard to really compare them. So
yeah, it's sort of apples and oranges of what we're looking at here. And to go along with Travis is following up and being part of that healthcare team for that patient. We're on the inside track of that. We have those acute care. It's almost, we sent the patient, we get a report back usually right after whether the interventions we did to that patient were good or we need to work on the interventions that the ED is expecting so that we can, on the next type of one we can do. This one is we have a specific patient type who has specific needs, and we're helping facilitate that. So as we're looking at where they're at in the program, are our interventions going to eventually help this person graduate from the program so that they can help themselves, or maybe graduate them to another level of care because it's getting to an acute or chronic thing that we no longer can do? We're right there at the forefront, and it's a lot different.
So intervention mechanisms are for all rights and purposes completely different in some scenarios. Is that
for
fair?
Sure. I think it depends on the initiative within the CHEMS program, because you can have CHEMS activities, to your point, of where the call originated in the 911 system. So for me, I think, if this answers your question correctly, maybe you guys can let me know, is it's not so much how the visits differ or the referral mechanism, but it's what the end goal is. And I would say
that's helpful.
I mean, I would think the biggest difference is just it's not just thinking we're going to ultimately potentially transport you to the emergency department. It's what else is happening. So Travis, his program is focused on kind of follow-up and what happens there. Some programs might have a community paramedic or a CHEMS provider going out on 911 calls and seeing if they can screen a patient to potentially go to a more appropriate destination than the emergency department. And so the call is still in the 911 system versus a follow-up, but the end result is, I think, a little bit different, and that might be the difference between 911 and CHEMS. Would you guys think so?
Yeah, definitely.
Okay.
How do you see CHEMS evolving in the next 5 to 10 years as agencies move forward? More hats?
That's a loaded question, yeah. I mean,
refined roles? There's lots of different directions that it could go.
Well, I think there is no better time than right now to be in EMS. I think everything from level of education to responsibility to ability of what you can do for a patient is changing. I think there are some great things happening even on the 911 side, separate from CHEMS or community paramedicine for EMS. So I don't think there's any better time than to be in EMS right now. And so that's why we say it's a little bit of a loaded question, because I think it's kind of open-ended right now. And it depends on medical community and education and so on and so forth. But I think it's a little bit open-ended, which is what's nice.
Which is great, so you don't hit a ceiling.
I don't think so.
We're in the building block phase of a new cultural shift in EMS, and the industry's going to change in the next 5 to 10 years dramatically. What we're doing today is going to be totally different than what we're doing in the next 5 to 10 years. EMS already changes every day, but it's changing at a much rapid pace. And right now, it's exciting for individuals like us because we're out of the box thinkers. So, and we're getting this CHEMS system in on the forefront rather than waiting for other people to develop it. We're developing it as we go. And I think that's exciting because we get to play a part as those building blocks and start setting them for ideas for others to take and move forward with. So that's exciting. This makes it so exciting to be part of the EMS cultural shift, if you would, that's happening right now.
Travis, you have anything to
I would
add to that?
say the same thing. You don't know what it's going to be like in 5 to 10 years, but I would hope that overall the state of Idaho will have a CHEMS provider in every community, and even expand that to maybe a paramedic in every community. So hopefully that would be the end result, but we'll continue to go through it and see where it goes.
Well, that's great, and all my questions are loaded, by the way.
Good point. I should have known.
And this one's really loaded.
Okay.
Okay, so if you were to just take a moment and imagine the transformation to a CHEMS agency, what do you wish you knew back then that you know now, that you would give as a token to people watching this?
That is a good question. Well, I think for me there would be kind of some structural, just basic things. Everything from, kind of make sure you are aware on outcomes and data and how are you going to schedule a community paramedic and some structural issues. But I think kind of the bigger picture for me, if I could give a token, is to go back, to be honest, to what we were talking about a little bit earlier, is to really embrace the uniqueness of what we do and be able to champion it. And then to look at that mind shift change of what EMS can be. And those would be, I think, the two biggest tokens I'd give someone.
Juan?
The biggest thing I think would be to embrace the cultural shift that's happening, and not make it such an uphill climb as you're building, and get not only your healthcare neighborhood involved, but get your members involved. Have them have a say in how that strategic planning is going to be, and come to the same conclusion of the outcomes you're looking for, the constituents that you're going to serve, and the service you're going to provide for them. And I think that's key and essential. And another thing too is make sure the inclusivity is huge, and not just with your membership or your agency, but all of the surrounding agencies. Make sure that inclusivity is huge so that you can build a good, diverse group of individuals with all attributes and skills so that they can come in and provide the information you need and help that communication hurdles as you go and make it much smoother.
Travis?
I would say try not to build a program all by yourself. There's already people that have created programs that you can start borrowing stuff from. And then outreaching is a big thing. I mean, talking to your region departments with the health and welfare, reaching out to hospice, home health, mental health specialists, and just putting yourself out there, and print off lots of business cards and expect lots of emails from people you have no idea who they are, but you figure it out in the end. I think those are your greatest resources to help build your program. So,
Fantastic. Well, thank you so much for your time today. I really appreciate it, and I'm sure that the people watching this in the future will appreciate your insight and your ideas as well. So thank you very much for your time today.
Thank you.
Thank you.